Good morning, everyone. Welcome, welcome. Get yourself a cup of tea or a cup of coffee and settle in on this dreary February morning. For those of you who are regular attendees, you know the drill. Could you, everyone, please, as you leave, fill out an evaluation form? It's very important for us as we plan this series in the months and years ahead. If you'd like to sign up for continuing education credits, APA credits, CMEs, you also need to fill out an additional evaluation form that is in the back of the room and also sign in and out. So it is my absolute pleasure to introduce to you this morning someone that you probably already know, Dr. Shari Barkin. And Shari has a very interesting history. She's been kind of all over the place. She got her bachelor's in zoology and education. I didn't know that about you, all right, at Duke University. And then she went on to get her MD at the University of Cincinnati and did her pediatric fellowship at Children's Hospital of Los Angeles, and then earned her degree in health services research at a place that's near and dear to me, UCLA. And we were fortunate enough to recruit her here to Vanderbilt, where Shari has just, in my mind, not only assumed a leadership position as the division chief of General Pediatrics, which is a daunting task, but she has also really pioneered and launched a line of research that we'll hear about this morning that, in my mind, is some of the most important work that pediatricians could ever do. Shari is the Marian Wright Edelman Professor of Pediatrics, and as I thought about this morning, I thought, you know, what a perfect chair for you, because I think just like Marian Wright Edelman didn't shy away from hard things, Shari's research doesn't shy away from hard things. You tackle some of the hardest questions about children, violence in kids, obesity, not little minor things, huge problems, and you're doing a fantastic job. So with a warm welcome on this dreary day, please join me in welcoming Shari Barkin.
Good morning, everybody. Well, that certainly brightened my dreary February day. Thank you for such a lovely introduction. And it really is an honor to be here today to talk with you about a topic. I see many colleagues in the audience, several experts in the area of obesity. So the first part might be review for some of you. I just want to make sure we all start from the same place so that we can dive deep into the questions, look at some potential solutions, and then hopefully engage in an interesting discussion. I'm going to be talking today about pediatric obesity, prevention and control in the Latino population. And our objectives this morning are to understand the scope of the problem of pediatric obesity, identify contributing factors to the epidemic, understand pediatric obesity linked to diabetes in Latino populations, and then learn about some promising strategies to address pediatric obesity for Latinos. And I'll be presenting some of our research. So raise your hand if you've seen this. This is from the CDC website, right? Now, I noticed that only about 10% of you raised your hands, which is why I still put it in. And why, if you have seen this before, I'm going to ask you to focus your eyes a little bit differently. So the CDC started in the mid-'80s looking epidemiologically to see what's going on with obesity for adults, not for children. This is just adults. And they looked over this span of time. So we're going to take you through the 1990s, which feels like a long time ago, 1985 when we really weren't doing much surveillance. And we're going to go very quickly. I want it to be like a movie for you. So let me just orient you to color. So if it's blank, it's because we had no data. We weren't doing surveillance yet. If fewer than 10% of the adults in the state are morbidly obese, BMI greater than 30, that's going to be a lighter blue color. As it becomes darker blue, we're up to 15%. The colors will change, and you'll start to see yellow and then orange as we move to greater than 20% and greater than 25% of adult populations who are morbidly obese. Now, for those of you who have seen this, I want you to focus your eyes, find our state. So find Tennessee. Don't worry, it's not a geographic lesson, although I'm learning a lot of that from my children, relearning it. So I want you to focus on Tennessee and specifically the surrounding southeast area. So are you ready? We're just going to go quickly through this, and I'm going to stop at points that I think were nidus points that really changed the slope of the curve for obesity accelerating in America. So everyone see Tennessee, southeast? Focus there, and we're going to move to do you see we're in 1996 now? Did you see how quickly that went from blue to yellow? So 1997 to 99. Okay, yellow, greater than or equal to 20% of the adult population. So I want you to think 1999. What happened? What happened that made this epidemic look like it tips? So keep watching. Southeast region. Do you see we get orange? Where does it happen first? Southeast region. And then what happens? It's like a contagion. It spreads. So we seem to be the hotbed of where the epidemic seems to increase first and how it then spreads across the country. This dark orange color, greater than or equal to 30% of the adult population, not as overweight, but as morbidly obese. And that was the last slide. So I want you to see and understand the questions that we started to ask. And most of my research, when I was in California, my research was all about violence prevention. I'm a public health scientist, I'm a health services researcher, and all of my questions come from what I see in clinic. And I was inspired to really investigate violence prevention because it seemed like I was seeing absolutely preventable things walking into the emergency room in the clinic. And I switched to obesity about 6 years ago because in the clinic, I noticeably could see that over a 7-year period of time of me being in clinic, I could see in my Latino families, with my own eyes, no microscope needed, that this had become an epidemic that had tipped in North Carolina. So, and I was there in 1999, and I was there in 2004. So what happened? I want you to just think about that in your mind. What would happen to make something tip like that? So what about childhood obesity? As I mentioned, those slides have nothing to do with children. Or do they? Do adults have something to do with children? Does adult obesity have something to do with childhood obesity? I would posit absolutely multiple mechanisms for why we believe that that's true. So in childhood obesity, and sort of raise your hands if you know definitions of obesity in children. Okay, so obesity is defined as an excessively high amount of body fat or adipose tissue in relation to lean body mass. I saw an 8-year-old in clinic. When I looked at his chart before we went in, it looked like he was going to be morbidly obese. And when I walked in for this 8-year-old, he had muscles like he was a 16-year-old. And we actually diagnosed precocious puberty for him. He didn't have any adipose tissue at all. So just having a high BMI, which we'll talk about in a minute, doesn't make the diagnosis. You have to look at the body habitus. Now, because children grow at different ages, and because the genders grow differently, the CDC provides this guideline for how we say, are you overweight and are you obese? It's beyond weight. It's body mass index, and that looks at your weight in relationship to your height. And when I talk to families in clinic, I don't say, the CDC guidelines indicate that you are morbidly obese. And with my Latino families, I don't even say sobrepesos. I don't say overweight. I say your weight is growing much faster than your height, and that's not good for your health. That's what body mass index is about. So overweight, and it's recently redefined in the past 2.5 years from the CDC, overweight is defined as greater than or equal to the 85th percentile of age, gender specific. I'm going to explain what that means in a minute. And obese defined as greater than or equal to the 95th percentile for age and gender specific. And studies suggest that cutoff points are not universal for ethnicities. So let me just briefly explain, what is this percentile thing all about? So raise your hand if you have children or grandchildren in your life. So when you go to the doctor's office, they might show you our curves. We're looking to see if you're growing along your own curve and if it's somewhere in the normal range. So we say greater than the 5th percentile, less than the 90th percentile of growth along your curves usually is normal and healthy. Although we've been learning that rate of rise for how fast you grow for your weight more excessively than your height actually does appear to be a risk factor. So we're looking at percentiles. And I'm about to tell you that more people, that 1 in 4 children walking into our clinic are overweight. And you're going to say, that doesn't make sense because that's greater than the 85th percentile. Shouldn't that be 15% of people and not 25%? And so what happened is we held these curves constant. We noticed that the rate of rise for weight was excessive, defies how genetics can change so quickly over a short period of time as we looked at to begin with. And instead we held the curves constant to say this is still what we believe healthy growth patterns are, and we now have an excess amount of children that are growing in ways that are not healthy. That's why these percentiles might not fit together as you're listening to the next part of the story. So what is the connection between childhood and adulthood obesity? In 2000, 15% of children and adolescents aged 6 to 19 were overweight. So that's that greater than or equal to the 85th percentile. That still makes sense, right? Up from the 5th percentile in 1970. Overweight adolescents have a 70% risk of becoming overweight or obese adults. And 60% of overweight children, not obese yet, overweight, ages 5 to 10 already have 1 or more risk factors for heart disease or diabetes. Now, what that means is that what I believe this data tells us is that obesity starts early. That means prevention is going to have to start early. And it gets harder and harder to intervene upon. One other point that isn't on this slide that I think is important is that we know that if you are a preschooler, so you're 3 to 5 and you're overweight, you are 2 to 5 times as likely to be overweight in elementary school. It's almost like a chronic disease. It gets worse over time. There's a disproportionate effect with minority populations. Now, these data come from the CDC, and they're updated regularly. These data do not match what I see in clinic, and we see 35,000 patient visits on the 8th floor. Dr. Desmond can attest to that, who's in the audience as well. We see a lot of kids, enough as a population-based scientist that it makes me say that I think these statistics lag behind what reality is. So of 4 to 5-year-olds, white children, 4 to 5% are overweight. For African American children the same age, 12 to 15% are overweight. These are 4 to 5-year-olds. And for Latino children, 24 to 27% are overweight. I'll be presenting data from our randomized controlled trial that show numbers that are much higher than this for preschoolers. So what's going on? It seems that there's a disproportionate impact. And this, as many answers, will be a complicated answer. There are multiple things that contribute to this. One is culture. So in studies of Mexican American mothers, 60% of them misclassified their child. They did not see their child as overweight, and they didn't see them as unhealthy. And the majority of Mexican American mothers did not see a connection between weight and health. So if you have contact with Latinos in your life, personal or professional life, will you raise your hand? So do you know the word gordito? Gordito or gordita, it means chubby. It really means cherubic. And in fact, it's used as a term of endearment. And this is not new to Mexican American families. This is very much of an immigrant phenomenon. So I know that my grandparents, when they looked at my parents and they looked like they had chubby cheeks, they felt prosperous. They knew that they were doing a good job as parents. That's not the specific culture. There is a sense, an immigrant sense, that when you come with nothing and you try to build something for your family, you want to see overt signs of prosperity. That might not be the change in your pockets that jingles when you walk. It might be the way your child looks and how heartily they eat. This goes across many cultures and is very, very prominent in the Latino culture, which really views love and food inextricably. I can think of many other cultures that do that as well. I love this picture. After a short stay in America, Michelangelo's David statue has been brought back to Europe. So what happens to our immigrant families after they arrive in America? By their second generation, their health declines. And they become more obese. They have more incidence of diabetes. They have more incidence of heart disease. So it appears that America might not be that good for your health. Now, why would that be? So this is a review. I'm expecting many of you already know this, but I want to make sure we're all moving forward together so we can ask questions together. So, many people have a bias. When they see somebody that doesn't look right, they cross the other side of the street. I believe that we are a society that really does not see obesity as beautiful. We see people as gluttons. We say, can't they eat less? Why aren't they turning the TV off and being more active? Can't they just take some personal responsibility? Now you're going to see that those are some important questions, but this is a much more complicated problem. And I would like to sort of lay out that evidence for you so that you can understand why is it more complicated than just turning the television off, which I still advocate, by the way. So energy balance. It's all about calories in and calorie out, right? So I'm in the newborn nursery now, attending on service. We've got a premature baby, losing loads of weight, taking loads amount of calories in. We've increased those calories. We're making sure that this child is eating very efficiently because we don't want this child to burn any excess calories. Why is he still losing weight? Something else is revving up his motor. Is it infection? Is it that his temperature is dropping and he's working too hard to keep his temperature up? There's a lot that goes into that energy balance equation. Some of it that is internal that you can't see, and some of it that's external. I draw the seesaw for our families when they come in to understand that. So what's going on both sides of our seesaw right now in America? So we've got not such great dietary intake. You know how many vegetables we're now supposed to eat a day? How many servings? 9. Yvonne got that right. Most of us were thinking 5. I'm happy to get 5. 9. What percent of people in America that are not vegetarians get 9 servings? Any ideas? 3%. So this is not easy for any of us. Soft drink consumption has more than doubled. This is data from a longitudinal study of child development in Quebec. It suggests that children who regularly consume sugar-sweetened beverages, so that's our terminology that includes Gatorade, by the way, sorry to report, iced tea, sweet iced tea, sodas. From ages 2 to 4 years were more than twice as likely to be overweight by the time they're preschoolers. So when that 12-month-old rolls into our clinic and he's got Coke in his bottle, that doesn't fare well for him, right? Now, only 3% of populations meet the requirements. I'm afraid I'm even one of them, and I'm really thinking hard about this. It's hard to do. Now, portion sizes. So what we eat going in isn't so good, and how much we eat is huge. So we know that we like big gulps. We know that everything comes in giant cups. I remember when I was 7 and we went out to Hot Shops for dinner, I got a 6-ounce cup, and I got 1. They didn't keep refilling it mindlessly. We know about the supersized meals being 1 day's worth of calories, 1 supersized meal. And though we've seen some positive change in that direction, we have change agents in this audience working on that problem right now. So portion size. So just a word about that. We know that we are mindless eaters. We eat whatever is in front of us. There is fabulous and fascinating data about this. data that shows you that if I give you stale popcorn that has been sitting out for 2 weeks, and I say it's free, and you come in and I give you a small container, or I give you a big container, people will eat to the bottom of the bucket. But my favorite study that has been done, and I think that this was done at Yale, correct me if I'm wrong, it's either Yale or Oregon, where they had the soup bowl that refills. So now here's the idea. They gave you soup. They said, stop when you're full, basically. So here's your bowl of soup, but they rigged up a bowl of soup so that it endlessly kept refilling itself. You couldn't see it. You're not noticing how soup is being used up. Those people that had their bowl refilled over and over again ate 3 to 5 times as much. We are constantly overriding our homeostatic mechanism for eating. We are mindless eaters. Now that's important. It's an important contributor to this problem when you think about our built environment and when you think about portions that are served in restaurants and package sizes you purchase in the grocery store. Now what's going on for the out part of this energy expenditure equation? Well, 4 hours a day, the average American, 4 hours a day engaged in media use, that's when we didn't have all of that fancy handheld device that allows me to actually watch soap operas on my cell phone. I can do that. I'm not doing that. I could do that, right? So it doesn't include the instant messaging. We don't know what to make of that. What is that? That's sedentary. I'm pretty sure we don't burn a lot of calories when we do that. So it really works to be, and in fact we calculate this in our weight management clinic. We have double the number of clinics that we have for weight management clinic and general pediatrics to serve the demand. And what we find on average is that these kids are watching more than 40 hours of screen time a week. And I say to them, that's a full-time job. That is without benefits. So few physical demands are built into daily life. We were meant to be an agrarian society. So we were meant to actually expend a whole lot of calories and then eat as much as we could find, as much as we could grow, as much as we could catch. That's actually how our body is built. Now we are adaptable. That is fabulous about all life. We are adaptable. But we adapt to our environment. So it's this interaction that I really want you to think about. As age increases, activity decreases. So determinants of weight gain in children. Back to this question, we know from the CDC about this epidemic in adults. Does that impact children? Well, there are many studies to show that parental obesity is a key determinant of obesity risk in children. I'm going to show you some data from our studies that really solidify that in the Latino population. And some of it will be genetics, shared genetics, and some of it will be shared environmental risk factors, such as maternal intake of sweetened beverages, high-calorie snack foods, and takeout meals, all associated with children's intake of food. We eat what's in the pantry if we're home. We eat what we can afford when we're out. There are early life determinants of obesity, such as breastfeeding. Now, many studies to reconfirm that breastfeeding does decrease the risk of later obesity in very small amounts. So it's not confounded by sociocultural factors. Some studies show that an increased duration of breastfeeding is associated with a lower risk of obesity, a slightly lower risk, less than 5%. Rapid infant weight gain studies out just from a year and a half ago, Lunison et al. And JAMA, showed rapid infant weight gain that predicts childhood overweight at 4 years of age. So back to this notion of, is this kind of a chronic process? And what contributes to the chronicity of this problem? So we now look at the rate of rise of how fast you're gaining your weight in infancy. Because the notion is if you can control that to have a normal rate of rise, it appears to be associated with better health outcomes when you're older. More determinants of weight gain in children. We know poverty is a strong risk factor for childhood obesity. So in a study of Baltimore homeless shelters, 18% of children were overweight and 23% were obese. That was an old study, so I've changed it to reflect the CDC definition that I gave you. And none of the children or parents were underweight. Based on data from N. Haynes, 1999 to 2002, children from food insecure households, meaning you don't know where and when your next meal will be coming from, are likely to have a higher BMI. In fact, obesity is the most visible form of malnutrition that we have. I'm rereading a book called Let Them Eat Promises, which is about malnutrition in America in the 60s. It followed exactly the same pattern that I showed you from the CDC map. Started in the southeast, spread across the country. And where it started is where obesity started and how it spread. So critical elements for efficacious pediatric obesity interventions. This is from reports from the American Heart Association, the American Dietetic Association, and meta-analyses looking at what are some promising interventions in pediatric obesity. Well, they appear to include these 4 components: nutrition education, physical activity education, behavior modification, and parent training. We're going to talk about what that actually means and what that actually looks like. Obesity and diabetes. We know that this is linked. And in fact, Olshansky in the New England Journal of Medicine about 4 years ago did a study looking at the data and extrapolating if we continue on our trajectory, that 30 to 40% of children born in 2000 could go on to develop type 2 diabetes. But just because you're obese doesn't mean you're at risk for diabetes. In fact, we have a better understanding now that we realize that the largest endocrine organ appears to be our adipose tissue, depending on how much adipose tissue you have, that the adipokines that are released from your adipose tissue leads to an inflammatory pathway that appears to be associated with that onset of obesity. And it's visceral adiposity around your waist where it appears that you have more active adipokines at work. So those people that have generalized adiposity actually have fairly good outcomes. Those people that have visceral adiposity tend to have worse outcomes, moving into adolescence and adulthood. So now I'm just trying to focus us on Latinos in this issue. What we notice about Latinos is that they tend to have more visceral adiposity when they gain weight. They also have more than 74% of women having little or no leisure time physical activity. And we know physical activity is what is linked with insulin resistance. So that mechanism of insulin resistance leading us to diabetes. So the more physically active you are, regardless of whether you change your body mass index, we know the more insulin sensitive you become. And the less physical activity you have, the less insulin sensitive you become. So you're more at risk for diabetes. So it appears that our Latino population has these 2 risk factors. That when they become obese, it's mostly visceral adiposity, and they also have less time spent in physical activity. Now, I don't really have time to elucidate the mechanisms that we believe are at work here. They're multiple, and it's evolving. And every day I read a new article that I can add into my talk. So stay tuned. But I do want to give you a sense of these contributing factors. So we say, why visceral adiposity in Latinos? That must have to do with your genetics, which there's got to be the part of your body that says where your fat is going to be distributed. That mechanism and that code, that has to do with your genetics, right? So there have been genome-wide association studies and case control studies that reveal that genes are associated with obesity. And just to clarify for this audience, I'm talking about common forms of obesity, not the rare forms of obesity. The number of risk alleles, it appears, is highly correlated with average BMI for common forms of obesity. This is a genome-wide association study with more than 30,000 adults and it was looking in European populations. But the main thing that I wanted you to notice, and Dr. Willer was just here interviewing. We hope that she'll be able to come and join us here. This was from Nature Genetics 2009, that we see that for the 8 SNPs that they identified at that time, and now there are 34 1 year later, that you can see that the more alleles that you have, each SNP has 2 alleles. They looked at 8. So this is a risk score factor that takes you from 0 to 16 in terms of your risk with only these 8 single nucleotide polymorphisms. These are teeny tiny proteins. So you can see, though, with this 30,000 population-wide based study, you can see that the higher your allelic risk score for these 8 SNPs, the higher the likelihood that you would be obese, that your BMI increases in a clinically significant way. It's because of this paper that we collected saliva in the study that I'm about to present to you. But we know genetics can't tell us the whole story. And in fact, when you break out the contributing percentage of genetics to common forms of obesity, it appears to be quite small, 1–2% of the variability for obesity. So it plays a role, but it doesn't appear to play the most prominent center role. It plays an important role in the whole scope of other contributing factors. So when we look at causes of preventable mortality in general, here's our typical breakdown, that 40% of causes of preventable mortality is behavioral, typically 30% is genetic, 15% social or sociocultural, 10% healthcare shortfalls, and the rest environmental toxins. So from JAMA, this is a while ago, from 1993. So I think it'll be interesting for us as we continue to gather more data to try to understand the degree of contribution that each of these elements has towards these common forms of obesity to help guide us and understand what interventions will be effective. It's because of this complexity that our team looks at applying an ecologic model when we develop interventions. So raise your hand if you've heard of an ecologic model. Great. The World Health Organization uses this model. And the way that we look at this in terms of pediatrics is that you've got the level of the child and contributing factors from the level of the child, the level of the family, and that contributes to not only the family but to the child, what's happening in the community and how that impacts family and child, and then the larger society. And so most of our studies, we try to cross as many of these levels as possible as we're trying to work towards developing impactful interventions. This comes from the Institute of Medicine's view. So we're pausing and summarizing before we move now into interventions. So the Institute of Medicine has been looking at this issue for this decade, and they've been recognizing that pediatric obesity looms as a huge public health threat, as you can see, not just in childhood, but as it persists into adulthood. And looking at the fact that this is, you might notice the ecologic model, just laid out slightly differently, all of these levels contributing back to our energy balance equation. Because it's when this energy balance equation is out of whack and you have more calories in and fewer calories out, that you get this energy imbalance that leads to the obese child, who then typically will go on to become an obese adolescent and an obese adult. And I've spoken at the level of the child and genetics, the level of the family and shared environment. This is really looking at the social level. So we know from Christakis and Fowler in the New England Journal of Medicine 2007 that it appears that weight gain in one person is associated with weight gain in another, that a person's chances of becoming obese is increased by 57% if your good friend is also obese, by 40% if your sibling is obese, and 37% if your spouse is obese. I'm fascinated, actually, by this. I thought it would be reversed, to tell you the truth. But this is only for adults in a subsample from the Framingham study. So it's a very particular population. There were very few Latinos in the Framingham study. And it just really, I think, asks us to consider, is obesity socially contagious? This really says the same thing. Okay, now we're going to say, well, it seems to lead to poor outcomes. Could social contagion be used to lead to positive outcomes? Well, the same group showed that smoking cessation behavior by an index patient decreased a person's chances of smoking by 67%. Now, here's the direction that made more sense. If your spouse quits smoking, you are more likely to quit smoking. 25% if your siblings were likely to stop smoking, 36% for friends, and 34% among coworkers. So it appears that these effects are due to interpersonal relationship rather than geographic distance. And effects, again, from the Framingham subsample that we're looking at here, appear to be mitigated by higher educational levels. So what about Latinos? What about newer immigrant populations? What about lower acculturations? What about lower educational levels? So we were asking all of those questions now that you have this background. And the first study that we did is an NIH study called Tipping the Energy Balance in Latino Children. And none of our patients actually liked that title, so we called it En sus marcas, niños y padres juntos. So, which is on your mark. It used to be on your mark, get set, go, but we shortened it. Parents and children together, recognizing the strong impact of parent on child. And we were interested in this idea of how could we use a recreation center as an extension of the doctor's office to impact BMI for overweight Latino adolescents. Now, we started with adolescents because we were optimistic. We thought, let's intervene at an age where the child has decision-making capabilities and is interacting with their parents in a different way, that they're really an interactive dyad with independent decision-making. Also, there were many previously validated surveys that we could use as well. So that's why we focused on adolescents. This study was a randomized controlled trial. We enrolled 106 parent-child dyads. The age of the child was between 8 and 11. There was a BMI prerequisite of greater than or equal to the 85th percentile. And they all received care at a community clinic where 80% of our patients were Latino. So then parent-child dyads were randomized to either the intervention group or the control group. The intervention group was 6, we call them on-the-move clinics. Your first clinic happened in your doctor's office, and the next 5 monthly in your recreation center. We didn't talk about being active, we were active. That was part of the expectation of a healthy visit. And our partner was the YWCA. This is right at the time when I was transitioning from being at Wake Forest in North Carolina here, so I flew back and forth to finish this study with this population. Fabulous partner, the YWCA, full-service recreational community, community-based YWCA. And the control group, they had 2 on-the-move clinics, but they were clinic-based. Now, we did all of our studies are mixed methods. Before we launch our randomized controlled trial, we do a lot of qualitative work up front. We need to determine what's the right dose. What's the likelihood that families could attend a monthly session, a biweekly session, a daily session? What topics are appealing? What topics are low cost and translate into immediate action? So we held 3 focus groups before we decided final process and content. And that included the control group as well. Because of that, we enhanced our care for our control group. We provided a clinic-based setting in the control group where it was the prepared, proactive discussion. Everybody filled out what are they eating, how active are they before they walked into the doctor's office. The physician reviewed everything ahead of time so they could create a targeted conversation. And this was then followed by a 45-minute group health educator session where families were together. There's that social influence part. That was our control group. So we call that enhanced standard of care. So what happened in the intervention condition? For visit 1, provider, problem, focus, visit, and we only looked at activity. Because when you think of a recreation center, you think activity. We also, from our discussions with families, really heard loud and clear that play was a natural fit for children and eating their broccoli wasn't. So we wanted to get started with something where they could be successful, and that was activity. We used applications of brief principles of motivational interviewing, and we used a reciprocal parent-child contract to set goals, all based on the latest evidence from Len Epstein and his group in longitudinal trials. This was then followed by a 45-minute group health education session focused on functional activity, not expensive sign-up for gold gyms kind of activity. The next 2 to 6 visits were 20 minutes skills building, 30 minutes group activity, 10 minutes of contracting, with follow-up monthly phone calls over 6 months. I already mentioned to you what the control condition was. Now, I just wanted to let you know who were these people that participated. So this is just baseline demographic characteristics. Because of our eligibility criteria, the age should have been between 8 and 11, and it was. About 45% were males for the child. The BMI was, this is the absolute BMI for children, 25. That is overweight. That is overweight for an adult. When we looked at BMI percentile, we're at the 94th percentile. And what we noticed was that the majority of people in our study were not just overweight, they were obese. We initially tried to make this even, and we couldn't do it. We couldn't find enough Latino pre-adolescents who were merely overweight. And then we looked at media use, and it was fairly similar to what we know nationally, average media use of 3.1 hours a day of screen time, but pretty large standard deviation of 2.6 hours. For the adults, they were average age of 33, very low acculturation, mostly Spanish-speaking with friends and family. We used a version of the short acculturation scale. Most of them, of the parents that participated, were mothers, most of whom had low maternal education, with the majority not having completed high school. And their BMI, absolute BMI of 33, greater than 30, morbidly obese. This was not an eligibility criteria. This is what we found. So, briefly, because I'm aware of time, from baseline to 6 months, this study occurred over the duration of a 6-month period of time. We found, for all comers, intervention and control group participants, that 47% of the children that participated lost weight. Now, not a lot. This is BMI change. This is not weight change. But they lost weight consistently. Now, typically what we see in a population where there is no intervention, and I'll show you that coming soon, is that BMI continues to rise over time. So we could consider this as a stabilization of BMI. And 63% of parents that participated lost weight. Losing weight was not a goal of the study. We never said the words losing weight. We only focused on healthy lifestyles and being active with your children. When we looked at our hierarchical regression modeling predicting child absolute BMI change, and we chose that because our children were morbidly obese, the majority of them, that we looked at the dyads who completed baseline to 6 months. That was a 68% retention for a community-based study, which is right on par, a little bit better than most community-based studies. And just to notice, this really surprised us. Our control group was more effective than our intervention group. And we notice that the child's age impacts it. The older the child, the more likely their BMI would increase. The younger the child, the more likely it would decrease over that period of time. And we also noted that your baseline BMI is highly predictive of your later BMI. That's very consistent with the data that I presented earlier this morning. So what about this parent-child interaction? Is there a parent-child effect if the parent is obese and a parent loses or gains weight with their child? So we looked at all 72 parent-child dyads. So let me explain to you what this is. This is BMI change for the adult on this axis. So you're either losing BMI or you're gaining it over time, and absolute BMI change for the child. You're either losing it over time or you're gaining it over time. Each of them are dyadic. And if you're a plus, you're a girl, and if you're a star, you're a boy. So just to show you that in general, if I drew a line here, there was a correlation that was significant, that if your parent lost weight, that you would lose weight. I'm showing you the outliers to tell you the story, which is this particular parent lost 13 BMI points in 6 months. We never talked about losing weight. And that child lost 9 BMI points over 6 months. Over here, this parent gained about 5 BMI points, and this child gained about 2 BMI points. They're related. This is an important finding that hadn't been reported about parent-child dyads, how they interact, how they affect each other, and if this holds true for lower education Latino populations. So our study conclusion from this trial was for overweight Latino pre-adolescents, BMI change over time appears to be correlated with change in parental BMI. That a clinic-based intervention, which shocked us, that was completely the opposite of our hypothesis, with a group education component, appeared to be more effective than a recreation center-based intervention. And that interventions in this epidemic that disproportionately affect Latinos should focus on parent-child dyads. It also showed us that if you wait until your pre-adolescence, it's too late for prevention, which is why we moved on to this study. Salud con la familia, which means health with the family. The research question was, how does a lifestyle intervention affect weight trajectories in Latino preschoolers? And we were very fortunate to be funded by the state of Tennessee, as well as the Vanderbilt Institute of Clinical and Translational Research. And we've just received an extension grant from the state as well. This wasn't on purpose, but we knew we wanted to enroll at least 100 parent-child dyads. We enrolled 106. But this time we marched the age back to preschoolers, ages 2 to 5. And we randomized them, either to an intervention or a control group. Now, the intervention group was weekly because we believe, I haven't tossed out the notion that a recreation center-based program fails and we should never do it. It just really made me think about the dose effect of monthly recreation programs. And in fact, what has come out since we did our first trial was a meta-analysis that was published just a year ago to say that your dose has to be at least weekly for at least 3 months to show an effect. And that influenced how we organized this. So this was weekly for 3 months, 90-minute skills-building modules that really used the notion of building new social networks. The control group was 3 sessions, 60 minutes, had nothing to do with obesity. It was about school readiness. So the intervention included things like center and tour membership. We learned that a lot of families didn't know how to use their recreation center, even though it was free and accessible to them within 5 miles walking distance of their home. We worked on parenting and teaching appropriate limit setting, skills building in dyadic nutrition and physical activity. The control group include a library tour membership. Everybody got a library card, skills for reading with children, and strategies for bilingual success. We collected a lot of objective variables. We also learned that from M.S.H.S. We had a lot of self-reported variables for M.S.H.S. For this, we collected BMI, body composition using a BIA or bioelectrical impedance, and waist circumference because of visceral adiposity, as I discussed with you. We looked at parenting practice with the child feeding questionnaire and parental support of child's physical activity level. We looked at self-report for food intake, for physical activity, sleep, and screen time. And then we also used actigraphy. So they all, raise your hand if you know what an accelerometer is. It looks kind of like a little watch. We use the kind that attached to the waist because this kind of expenditure for the we is different than this kind of expenditure. So that's why we decided to use this waist-based accelerometry. Both parent and child wore this for 7 days. We also did genetic screening based on the data that I showed you. So I can tell you that as of yesterday, we just finalized sassification of our data set, which means everything is just right, conditions are perfect for us to now begin our final analysis. But to prepare for this talk today, I thought I'd give you a peek with our preliminary analysis. 95% of our parent participants were mothers, 89% of children were born in the US, while 83% of parents were born in Mexico. We are at that at-risk second generation. 80% of parents spoke only Spanish at home. Their SASH acculturation was 1.2. The scale is 0 to 4. 4 is highly acculturated. 0 is poorly acculturated. This is a low acculturation, even though the majority of them had been in the country for 10 years. 62% had some high school, and 21% had some kind of graduate equivalent. So just at baseline, the main things I wanted you to notice, we did not recruit overweight children and families. That was not part of our eligibility criteria. All comers coming to a recreation center, working on healthy lifestyles. And this is what we found. We found that BMI for age percentile, the mean was 69%. That's good, right? It's less than the 85th percentile. For parents, we saw that the mean BMI, see how close that mean BMI is to obese? Certainly overweight. We looked at baseline results for how active were these kids at the beginning of the study before we did anything. So this is the accelerometry data that I mentioned to you. And I'm just looking at how often are you sedentary. So sedentary means you guys are doing a pretty good job of being sedentary, right? Right? You're not asleep, I hope, right? That sleep looks different on actigraphy, but you're sedentary. And many of you aren't even fidgeting. Well done. But fidgeting burns calories, so please feel free. So what I want you to notice here that really surprised us is that we saw that of the wearing time, when they were awake over a 7-day period of time, during that awake period, 82% of their awake period was spent being absolutely sedentary, like you are right now. But here's the shock. These are preschoolers. Anybody have preschoolers in their lives? Right? 70% of their awake time, absolutely sedentary. This is contrary to childhood. It's just not what a toddler does, right? So now just a peek into what does it look like we're finding over time, okay? And wait for the final results, but I wanted to give you just a taste of it. I mentioned that it looked like our mean BMI percentile was good for this population. When we looked at what percent actually had a BMI greater than or equal to the 85th percentile, but less than the 95th percentile, 41%. Remember the data that I showed you from the CDC that said it's supposed to be 25 to 27%? Those that participated in the intervention group were twice as likely to change their weight category from overweight to normal in 3 months than those in the control condition who continued to increase their BMI over just a 3-month period of time. What could this mean? Now, huge grain of salt, please. This is preliminary data. I'll come back with my final data. We've got significant positive correlations between parent and child inactivity over the course of the day. In order to increase the activity level of Latino preschool-age children, parents are critical, right? They're critical in setting normative expectations. And family-based community interventions appear promising to change early BMI trajectories as long as that dose is powerful enough. It's got to be a weekly dose for at least 3 months. This month, we're bringing these same families back, and we're going to collect a third point to see what happened now 1 year after the study started. Pediatric obesity, if not curtailed, could lead to 1 in 3 adults with type 2 diabetes in the future, and the possibility that children will die before their parents. Latinos have a higher risk than other ethnicities, and interventions focused on parent-child dyads, clinic counseling for already overweight obesity, and community-based interventions in preschoolers show promise for addressing pediatric obesity in Latino populations. I just wanted to thank my team. Here's my North Carolina team from M.S.H.S Marcas. And here is my Salud con la Familia team here in Nashville. None of this is possible without a team. It takes a village to do a research project. So thank you, everybody. I'm open for a few questions if you're able to stay.
What do you know about children who attend preschool and their activity level and their weight, like Head Start?
Yeah. Well, it's interesting you mention that because we are working. Joan Randall is really leading this effort for our task force, our Tennessee Obesity Task Force, nicknamed TOT. And Joan, we're very fortunate to have leading our statewide plan for the CDC, and preschools and schools are a huge part of that. There's tremendous inconsistency. There are recommended standards. There is no reinforcement of standards. And people, human beings, we're good at sort of adapting to the easiest path possible. So I would say that there are voluntary standards and a lot of inconsistency. Much room for growth here.
Given what you said about weight being associated with prosperity in this culture, I wondered what the reactions were of the families who lost weight during that 3-month period.
Great. Well, actually, the whole concept of gordito and gordita and prosperity, that went right into our modules for discussions. So that what we did was we said, let's talk about this. How do you know your child is healthy? And we talked about what gordito means culturally versus what does it mean for your health. We created cognitive dissonance that led to a lot of discussion, and people started to understand health first rather than that visible sense of gordito. Now, my question, our team is wondering if we've got staying power. What happens when you're not constantly in this group, this social group that we've put together, creating new social networks? And we'll have data coming forth about that to show you that these kinds of interventions do create new social networks. And that data is just being run right now by Dr. Sabina Gazelle. That what we don't know is, does it sustain over time? And that's why we're delighted that the state has given us additional funding, because we need to ask that question. Other questions?
This is great, Shari. Could you say something about the fathers involved in the sample?
Great. So, here's something that's interesting. First, in our North Carolina study, we had very few fathers. There was one that was involved. And it's because he had been laid off of work. And he actually participated but felt slightly ashamed initially that he was there, because that's mother's work. And there's some really very clear lines at this point with our Mexican-American families that we've been working with. But what we found in the Salud con la Familia study, which of course was done right in the middle of an economic recession, and people were losing their jobs anyway, is that the mothers would start to come. If they liked it, the next session they brought the fathers. And we've actually tracked this. We didn't intend this at all. We just started noticing it. And then if they really liked it, they would bring their cousins. And maybe their neighbors. So we actually have those as process data, that first you have to prove that it's worthwhile. Secondly, you have to prove that it goes beyond the mother. So, and I think we're going to need to have some debriefing interviews with fathers to better understand their role. We do know that fathers often control the money, and they can say, fix me this for dinner, whether it's healthy or not. So there's a lot of decision-making power there, and it will be important. But paradoxically, we find that it's change in mothers over time. And if they're losing weight or not, that seems to be correlated with change in their child. Thank you.
Thanks for that wonderful presentation. I have to ask, sitting in this building, do you know if there were children with disabilities in your groups, either in North Carolina or here?
They did not have disabilities that I knew of, that were obvious or knew of, and we didn't ask about that either.
Well, thank you.
I think we have one more question.
Once a week is a pretty intensive intervention, and I was wondering, were most of the families able to come to most of the sessions and to stick with it through that time, or was that difficult for the families to do?
This is the challenge of community-based work. Community-based work that's about prevention is hugely challenging for retention. We spend a lot of time on recruitment and retention for this kind of work. And we found that we had a 66% retention, which is consistent with community-based trials over time. And those people that we lost over time, some of them were, had to move out of the state, and several lost their jobs and lost the ability to continue in the study, because then comes Maslow's hierarchy of need. And where does this study fit into what I need to do? So we track specifically why we lost people over time. We always do that. But it was fairly consistent, I'm surprised to say, with the other study. It's important. Retention is just crucial for us to make sure we're answering our questions. Thank you, everybody, for this opportunity.